Well, welcome everybody. As everybody's getting on, we'll maybe just wait another minute here before we start. Are we still letting people in, Carrie, or are we getting close to?
Surprisingly, we're at 83 participants, which is fabulous, but it looks to me like they're slowly still trickling in.
Okay. All right. Let's give it
So maybe wait another 20 seconds.
Yeah, sounds good.
I think you can start now, Stephanie. It looks like it's stalled.
Okay, that sounds great. Okay, good. Well, welcome everyone. This webinar is hosted by Great Plains Quality Innovation Network, the Centers for Medicare and Medicaid Services Quality Innovation Network Quality Improvement Organization for North Dakota and South Dakota. My name is Stephanie Hansen, and I'm a Quality Improvement Advisor for Great Plains Quality Innovation Network and South Dakota Foundation for Medical Care. I want to thank you for joining us today. Before we begin, there are a few housekeeping items to review. Today's webinar is being recorded and will be posted within 1 to 2 business days on our website at greatplainsquin.org. All lines will be muted throughout the presentation. Please add any questions or comments to the chat. We will allow time at the end of the presentation to respond. We have 2 exceptional speakers today. One will share a personal patient story, and then we will hear from Avera St. Luke Hospital. To begin, my colleague Stephanie Meduna will start us out with an introduction and some background information on sepsis.
You're muted, Stephanie.
There we go. Okay, thanks so much for that, Stephanie. So today we're just going to get started with a little bit of background about sepsis. We'll be sharing some data and why we're talking about sepsis along with some other tools. We will have a sepsis survivor joining us, and sharing her story of her family. And then we would like to hear about your work related to sepsis as well. So a little bit of background. In North Dakota and South Dakota, sepsis is the #1 admission and readmission diagnosis. With sepsis, time is of the essence. For every hour of delayed treatment, the risk of death increases by between 4 and 9%. Experts say that 80% of sepsis deaths could be prevented if they were treated on time. We have talked about sepsis in the past, but why are we talking about it again? It is with the observations from data and in the news, sepsis related deaths are on the rise. We will be sending out the handouts to attendees, so you will have all the links, and one of them is the link to this article that I'm going to be sharing with you from the Association of American Medical Colleagues. It contains so much important information about sepsis, including current sepsis treatment guidelines. We could easily do a 4-part series on this, as we have done in the past, but today we're going to focus on educating and collaborating with the community to recognize and address sepsis early. So with that being said, sepsis is the 3rd leading cause of death in U.S. hospitals, but quick action can save lives. Sepsis-related deaths declined from between 2020 and 2019. Increase was noted in 2019, those that were aged 65 and older. further increase in 2021 with that same age group. 87% of cases start outside of the hospital. About 50% of the cases experience some sort of post-sepsis syndrome. And review sepsis guidelines were updated back in 2021. For those who are on the call and are not clinical people, sepsis is not the infection itself. It is the body's response to the infection. Recent statistics show that about 1/3 of deaths in the hospital are sepsis related. So some of you probably know sepsis, called blood poisoning, as it was called that in the past. It is a life-threatening emergency that happens when your body's response to an infection damages those vital organs and often can cause death. It kills up to 350,000 adults each year in the United States. So right now I'm going to visit about a few risk factors. The first one we're going to talk about is age. People over the age of 65, as well as infants, are at increased risk. Weakened immune system is the next risk factor. Individuals with a weakened immune responses, such as those being treated for cancer or people with HIV, are more susceptible to sepsis. Chronic diseases such as diabetes, kidney disease, COPD can weaken that immune system and increase the risk. Severe illness or hospitalization also puts one at risk. Patients who have recently experienced severe illness, surgery, or hospitalization, including severe COVID-19 cases. Also consider any recent wound, cut, or injury. Common infections such as UTIs, pneumonia, can worsen and organisms can spread into the bloodstream. Then we also got to worry about devices and catheters. The presence of devices within the body, such as a urinary catheter or an IV catheter or breathing tubes, can lead to infections that may progress to sepsis. Antibiotic use and corticosteroids. This is the treatment with antibiotics in last 90 days increases the risk as well. Conditions requiring corticosteroid treatment, which can lower immune response, also contribute to susceptibility. As I already shared, sepsis most often starts at home or in the community. So it is good to learn and share the symptoms. So some of the symptoms we have listed here: low blood pressure, low oxygen levels, low urine output, absent bowel sounds, confusion, shortness of breath, fever, and they just feel like they're going to die at times. We also want to make sure that we use the time mnemonic developed by the Sepsis Alliance. So the T stands for temperature. We want to make sure we monitor that, whether it's being high or being low. I is for infection. You may have signs and symptoms of an infection that is showing up. M is for that mental decline, those that are showing confusion, sleepiness, or are difficult to arouse. And then E is for extremely ill, where there may be suffering from severe pain, some discomfort, or some shortness of breath. We have learned that one of the most important things can be to say the words, "Could I have sepsis?" And for the EMS to report and receiving provider, this patient meets the criteria for sepsis. So being on top of that and thinking about those signs and symptoms and thinking, could I have sepsis, may just save your life. The risk of mortality from sepsis increases by 4 to 9% for every hour that that treatment is delayed. As many as 80% of septic shock patients can be saved with the rapid diagnosis and treatment. For the health professionals, there are several different other things that you can also look for. You can look for inflammation, high white blood count, immature white blood cells in the circulation, elevated plasma or C-reactive protein, and elevated procalcitonin. Hemodynamically, you're going to be looking at low blood pressures, low central venous or mixed venous oxygen saturations, and a high cardiac index. You may notice some organ dysfunction where they're having that low oxygen level. They're not having very good urine output. Their creatinine may be high. Coagulation and clotting abnormalities may be seen. May have absent bowel sounds, the low plates in the blood as well, and high bilirubin levels. Some of the tissue perfusion that you may see is that high lactate in the blood and also decreased capillary filling or mottling. So here is one of the tools that we have on the Great Plains QIN website. It is protocols for early recognition of sepsis that helps get that diagnosis flowing and get the treatment started. So there are protocols for that action and treatment as well. And like I said, Great Plains QIN has developed this sepsis stop and tell tool. And this tool can be utilized within the organization. It can be used by staff members, or it can be used by family members or visitors that are in seeing a loved one. And just by looking at some of these symptoms may alert the person of what could be going on with them. Those people that see their loved ones day after day may notice something different than one of the staff members and what they're seeing. All right, Stephanie, I'm going to turn it back over to you.
Yeah, great. Well, thank you, Stephanie. I would now like to introduce our first speaker. Katie Burkett is a registered nurse and a program director for South Dakota Foundation for Medical Care. She has previously done a lot of work with Great Plains QIN as a quality improvement advisor, including work with sepsis. Today, she will share a personal story involving her mom. All right, go ahead, Katie.
All right. Well, welcome everyone. Bear with me. This is my little story, but I'm going to tell you about my mom's journey through her sepsis. And as it's quite a testament to the importance of early recognition, just like we talked about, quick intervention, that coordinated care, and really the power of protocols. So this is my mom. So let me tell you a little bit about my mom. She is a whirlwind of energy. My mom never sits still. She has 3 jobs still, only really because she gets bored and she loves to be out being social. And she really, medically, she isn't on any medication, really no health issues. She was never hospitalized ever, besides having us 3 girls, never has had a surgery in her life beyond colonoscopies, and really described as a 75-year-old healthy female. One would say she is stubborn. That might be me that says that. And that might also kind of factor into the story a little bit. But by the way, when digging for pictures with me and my mom, it reminded me how fast photos outdate. And it's time to be better about taking photos. So, a little PSA for everybody on that. If you get something away from that, take more photos. So again, symptoms of sepsis. We just kind of talked about this. But with that being said, here again is my mom's story. So it was Thursday before Easter this year, and my mom had symptoms of a stomach bug, right? We all get it. She assumed, like most bugs, it will pass. However, she didn't have any vomiting, no diarrhea, just really severe stomach pain, she said, and cramps that would come and go. Again, raise your hand. We've all had this, and it usually within 24 hours, it does go away. So really no sense of concern at this point. So by the next morning, though, with no sleep and the pain intensifying, it was feeling like it could be more than just the flu. She felt that maybe she needed to be checked out, so she called the local clinic here and they got her in right after lunch. At arrival to the clinic, the provider felt that this was much more than just a little bug and immediately sent her to the emergency department and ordered a CAT scan. The pain was getting pretty intense at this time, and her demeanor, they said, was not like really being her. Being in a small town, people know everybody, and they knew that it was very uncharacteristic for her to act this way. So a side note, she didn't contact any of her family because, again, of course, she just had a stomach bug and it wasn't a big deal. But she finally agreed to let staff contact her family after much persuasion, stubborn. And that's my mom. But upon immediate arrival, I was informed that my mom had a ruptured appendix. She was being prepped to be transferred to a tertiary hospital for surgery. And one thought I did have, I kind of had the thought knowing, with a ruptured appendix, she is at risk for sepsis. And that did kind of cross my mind a little bit. And on the slide, I do have the symptoms of sepsis listed. Again, we, just talked about all them, but nothing is cookie cutter in sepsis. If I can take one thing away, nothing is cookie cutter. So looking at her problems, she had no fever. She had pain. Her skin color was fine, I guess. She wasn't sleepy or really confused. Again, she was in pain and really not short of breath at all. No red flags of sepsis at this point. So, she's got pain and she's not herself. Next slide. But with me spending many hours teaching sepsis, I've been on these calls over and over and over and, sitting on webinars and teaching it. The question I did have, could this be sepsis? It's triggering in my head. I am asking that question. Could this be sepsis? When I entered the room, I could see she was not herself at all and much different from the initial report I received. Instead of my spidey senses were tingling, I could say it was my sepsis senses were tingling. Her BP, when I looked at the monitor, was 90s over 50s. They were taking about every 5 to 10 minutes. Her pulse was tachy, 110. She was afebrile still at this time. Her O2 sat was 96%, which is great, but she was on 2 liters. I'm like, my mom's on 2 liters of oxygen and she's 96%. Okay. She was somewhat foggy mental status, but again, she doesn't feel good. Her color, I thought, was pale at this time. So remember, sepsis is so sneaky. It looks different for everyone. Again, not a cookie cutter. It may show all the symptoms or it may not. But eventually, when it takes hold, it can go like wildfire. And sometimes the symptoms can be late signs of the progression. So again, always be thinking, could this be sepsis? It's good to have that in your brain. Or could this even turn into sepsis is another great question. Next slide. So as I'm taking this all in, the nurse recapped me the results of her CT. But my brain wasn't really listening. All I could think about is if this is sepsis, they should be doing something. They should be getting going on this. I wasn't even taking the time to look around and actually see what they were doing or what was going on. The doctor now entered the room and explained her condition and lab findings, stating her white count was over 34,000. And before I could say another word, he stated that blood cultures had been collected, antibiotics were infusing, lactate levels had been collected, morphine was given for her pain, and contact had been made with the surgeon and were waiting on EMS transportation to the accepting facility. Wow. He said, your mom is septic and we are following the sepsis protocol. There it was. The words, she is septic. They were on it. They were already way ahead of me in my little brain where it was going. They were following protocol. All team members knew the plan. They all know what to watch for, what to do, and what were the next steps. They already asked themselves, could this be sepsis? The moment she probably walked into their room. As you see from my slide, there are oodles of sepsis protocols, very similar in nature, following best practices. Which one's best? I don't know, not sure, but they were using their protocol, all on the same page, as a team, positioning this patient for the best possible outcome. Next slide. So my mom was soon transferred an hour away to the advanced care she needed. Concerned, yes. but reassured they were doing everything that was the right things for her at that time. So upon arrival, the receiving facility was ready. They had received a great report from the transferring facility. EMS gave a nice handoff. I was there, and that process of being prepped for surgery was great. Mom was afebrile, which was great prior to the transfer, but the time she hit the doors of the receiving facility, she had 104 temp. Again, wildfire. Blood pressure wasn't much better, remained tacky, and her O2 was on. Had a foggy demeanor, but was it sepsis or my mom had morphine? I'm not sure. Maybe both. Immediately, Tylenol IV was given, and I was once again told, we will continue to follow sepsis protocol. Again, music to my ears. Again, all the webinars I've been sitting through, all these countless times, that is music to my ears. Surgeon arrived, and he really didn't sugarcoat it in honesty, which is great, professional and honest. He says, your mom looks okay, but she is truly very ill. Plan for a long haul post-operatively. That's not music to my ears, but I really appreciated the honesty and the reality of it. Surgery team came in, stellar staff, good job them. They were so kind, so informative, and also asking questions that I knew were part of that sepsis protocol. Obviously well aware of what they were dealing with, good communication. Surgery completed with the surgeon stating, I cannot believe your mom looked as good as she did because inside she was a complete mess. She looked like a bomb went off. He said that over and over. It looked like a bomb went off. She is very lucky she came in when she did, guessing this was brewing for a while by the looks of it. Again, we think, oh, it's a stomach bug. It'll go away. It's all fine. But no, it wasn't. He was very clear that the next few days were going to be rough and will require close monitoring because she is septic. So key here, it is all about the time, as Stephanie had just said. It is about the time. And I told you, it can go like wildfire and you blink your eye. So rapid diagnosis and treatment. And my mom was getting just that. So immediate post-operatively, her urine output wasn't within normal limits, definitely watching those kidneys because we all know that's the first that gets hit. Over the next hours and days, she developed an ileus. Abdomen was very distended, a lot of pain. She was vomiting, so I felt like we were going backwards a little bit. Her JP was draining copious amounts of purulent drainage. It was amazing how much that was coming out. Very long and uncomfortable days for her, again, with the ileus and all that. At this point, she kept saying, I didn't realize I was this sick. I can't believe I'm septic. She goes, I know some people that had died from this. So my mom is not medical one bit. So this is one small win for us, that she knew what sepsis was and aware that, what it really meant. And so for the public, it's coming. They are getting to know what sepsis is, and hopefully they'll keep getting better and better at it. So we turned small corner on day 5, but still recovering from the postoperative ileus. And this remained an issue for several weeks, honestly, and maybe not even great to this day. Her vitals weren't baseline on day 5. Blood pressure slowly coming up, a little less tacky, but at least afebrile. Day 6 was discharge. I kind of felt that it was a little quick, but oh well, taking her home. She ate pudding and they said, ta-da, you're good. She even agreed to let me stay with her in her home for a few days. So I knew she still was not feeling well. At home, she was slow. Bowels were not functioning well, quite weak, easily fatigued, absolutely no appetite. Again, this is really life-changing for my on-the-go mom. Maybe she was even becoming a little depressed on it. So the first few days were rough, no doubt, at home. Honestly, the next couple of weeks were very rough too. So which leads me to the continued sepsis care. Sepsis just doesn't go away. You don't get discharged and say, oh, you're done, sepsis is gone. No, it takes time. Effects can be weeks for some months, and maybe even years or a lifetime. So we can't just discharge them and say they're good. Day by day, she slowly improved. She had a few setbacks, but there were 3 months, I don't know, 5 months out. She is doing well, and she is back to herself for the most part. So this is where maybe as healthcare providers, I would say we can improve on discharging a patient with sepsis. Post-sepsis syndrome is real. And will say it was not discussed upon discharge. This is life-changing for many, depending on the outcome. So we all know that many can be discharged with very long road ahead of them and recovery issues for them. So prepare your patients for this. And I really can't express that enough. The more that they know it's okay that you're not going to feel good and it's okay, it's going to be slow, that's normal. This is the normal process of sepsis. I think, if there's one area we're really good at identifying and, doing things like that, but I would really kind of hone into your healthcare providers to really talk about the post-care of sepsis. Next slide. So long and short, this is my mom's sepsis story, and it is a success story of sepsis. It is a story that shows that our hard work in healthcare does pay off. This is a celebration. It proves that sepsis protocols and shared best practices in our healthcare facility improves outcomes and, yes, sometimes lives. We hear so many stories of what was missed and this went wrong and they should do better at this. And then, oh, yes, and I'm in quality, so I will advocate. There is always room for improvement. I do know, however, that even with the best care and following of protocols, we do lose patients. Sepsis kills. Moms, dads, spouses, and even children. Anyone can get an infection, and almost any infection can lead to sepsis. We cannot let up the gas here. However, I'm here to say, good job, healthcare. Keep striving to improve and keep giving that responsive quality care that you are. And my ask for you is this: do you have a sepsis protocol? And if you do, are you following it? And do you review it quarterly, annually, whatever? And does everybody know their role in that sepsis protocol? Because I think the great communication, the great handoffs, all of that was definitely a success in my mom's story. But last and not least, always think, could this be sepsis? So thank you all for joining, listening to my story, and keep doing the great work and give yourself a pat on the back because we are making a difference. Good job.
Thank you, Katie. That was such a great story, and I'm so glad that your mom has come through and is doing so much better now. Thanks again for sharing. That was powerful. So next, I would like to introduce our next speaker, Melissa Waldner. She attended nursing school in Brookings, South Dakota at SDSU, where she received her RN BSN degree. She started working for Avera St. Luke's as an RN in 2009. She left Avera in 2018 to move to Florida. She worked there on a cardiac unit and ended up moving back to South Dakota in 2020 and started working for Avera St. Luke's Hospital again. She has worked as a charge nurse for many years, a clinical instructor part-time for SDSU, and took the nurse educator position in 2023. She is currently pursuing a master's degree in nursing education. Melissa will discuss an overview of efforts, data, successes, challenges, and escape room during her presentation. We appreciate your time and want to thank you for being with us today, Melissa. You can go ahead.
All right. Good afternoon, everybody. Like she said, my name is Melissa Waldner. I will be presenting about improving sepsis compliance at Avera St. Luke's by utilizing an interprofessional collaborative approach. Right away, I'd like to just really give credit to Suzanne Vogel. She's our quality specialist here at Avera, and she's really the leader and driver of all of the changes in our sepsis protocol here, and I just kind of agreed to do the presentation here, but I helped a little bit. But so objectives, provide a general overview of sepsis. That's already been done, so I'll just skip my first two slides. I don't want to duplicate any information here, but I'll discuss why sepsis compliance is important. I'll share changes that we implemented here to improve our compliance. I'll provide some visual data that shows how we've tracked our sepsis compliance here. And then I'll discuss challenges or barriers we've encountered, and then I'll share some applicability to the rural healthcare setting and critical access hospitals. So I'm just going to skip those slides. Like I said, I don't want to duplicate anything. So why focus on sepsis bundle compliance? Really, number one is to improve health outcomes for patients diagnosed with sepsis, control healthcare costs related to sepsis treatment, And then the CMS is proposing to adopt Sepsis 1 into its hospital value-based purchasing program beginning in the fiscal year 2026. And nationally, the average Sepsis 1 bundle compliance is only 50%. So our why really is our value-based purchasing, and then our performance history with our Sepsis 1 compliance really wasn't that great when we started talking about how can we make this better. Value-based purchasing ensures accountability for providing high quality and value care and for increased patient satisfaction. The hospital value-based purchasing program rewards acute care hospitals with incentive payments for the quality of care provided. So, like I said, we weren't doing so well. March of 2023, April of 2023, we were at around that 50 percentile range. So we started talking about how can we improve sepsis compliance right around here in May of 2023. We implemented most of our major changes right around September of 2023. So you can see right after we made a few changes, our compliance greatly improved there. And then the last data I had available in April or May here, our year to date was 82% and the benchmark was 84. So we're really close to the benchmark. Our May data wasn't complete when I had made this presentation. So hopefully we're getting there. Yeah, so we looked at our sepsis fallout distribution. So fluid and IV antibiotics were really our biggest challenges and opportunities for both 2022 and 2023. So we used a root cause analysis to find out where are the barriers here? Like, why are we not being compliant? Like, what's happening here? So Suzanne Vogel brought the issue to our nurse practice council, and we really just kept asking why, like, why aren't blood cultures being collected in a timely manner? Why are the sepsis protocols not being used, that kind of thing. So we did end up identifying that timeliness of blood culture collection was a big issue, handoff communication, confusion with the workflow with the quality indicator tool, and lack of utilization of order sets by providers. Let's see. So how did we improve compliance? I have a timeline here. So again, we started talking about it. What are we going to do about it? May of 2023. And then in September, it was brought to our nurse practice council to kind of, like I said, brainstorm and figure out like, what are we missing here? We did do a mandatory sepsis escape room, which I'll talk about more in a little bit here in September of 2023. And then from there, we did other things like we had a multidisciplinary team meeting. We implemented the QIN device in our emergency department. We had reset education with our physicians. We developed a new sepsis quality indicator tool, and that's when the Sepsis 1 bundle went into value-based purchasing here in January 2024. We did hire a new abstractor at St. Luke's here, and then we implemented that new sepsis quality indicator tool. We put that into use here. And then in April, this last spring, we did a sepsis station at the skills fair. And then currently just discussing what we're doing for Sepsis Awareness Month in September here. So hopefully we will continue our trend in the positive direction. Those are just the major things we did, but other things that you can do during Sepsis Awareness Month is like I had a public bulletin board that even our visitors could see on one of our busier units, and kind of talked about what is sepsis and talked about the time thing and asking the question like Stephanie mentioned. Again, did the sepsis escape room. We did provide some one-on-one education with staff regarding our sepsis surveillance, which is available on our electronic health record. We use Meditech Expanse here. So there is a sepsis surveillance with that system. We also implemented a sepsis alert on our Volt phones. it does get paged to our phones, but it's not called overhead like in a medical emergency. And I did add sepsis and sepsis surveillance to our new higher education and onboarding, so that way new staff know that it's important to us and they know what to do when their patient flags for sepsis. So we did a lot of different things. Next, I'll discuss 3 key interventions we implemented. Number 1 was the sepsis escape room. So Suzanne approached me again, like, well, how can we educate about sepsis? And I really just didn't want to do the same old thing for education. I wanted to do something fun and different. So I got a referral to the South Dakota Association for Nursing Professional Development because I did an interview for Sadaho and they interviewed me for our hospital here, and then they ended up referring me to this group, which was awesome because then I met Michelle Hofer in the South Dakota ANPD group, and she gave me all the resources to develop a sepsis escape room. So really good networking there. I really kind of threw the idea out at our nurse practice council meeting, and everybody's like, yeah, that'll be really cool. And then all of a sudden I'm like, oh no, what did I get myself into? Like, I didn't know how I was going to pull it off, but I'll talk about that here in a second. So just some information on sepsis escape rooms or escape rooms in general. Gaming is an emerging teaching methodology. It increases content retention. It encourages critical thinking, strategizing, and performing under pressure. It incorporates teamwork or team steps, which helps optimize team performance across the healthcare delivery system. It involves communication, team leadership, situation monitoring, and mutual support. And then escape rooms give additional gaming, develops active problem-based learning environment. So it provides that experiential education, it enhances learning, and it stimulates interest and motivation. The teamwork thing was something that I didn't realize came with the escape room, and someone pointed it out as you know, it was unfolding, and I was like, yeah, you're right. You really are. We're encouraging them to work together to figure out how they're going to get out of this room. So the objectives I had for my escape room were that staff will identify infection screening symptoms, staff will identify SIRS, sepsis, severe sepsis, and septic shock criteria. Staff will follow the appropriate pathway on the sepsis quality indicator tool, and staff will provide the patient the proper treatment protocol. Overview of my escape room was that teams will work through a sepsis case study by following multiple clues to treat the patient appropriately and break out of the room. The team with the fastest time will be spotlighted in daily lineup and receive a sweet surprise. So just some considerations if you're thinking about doing an escape room is to establish rules for the escape room to ensure appropriate flow. So the rules that I had included a maximum number of team members, time limit for the room. I had to provide an order to unlock the items. And then I also had made a rule that if any steps were skipped, it added minutes to the final time. So no sharing of information was the main rule, and I was really surprised that nobody told my secrets. So just adding that little bit of competition of having those bragging rights and a sweet treat at the end, really, I don't know, maybe it's just people are competitive here, but they kept it a secret, and I was just really thankful for that. Another thing is just keep it simple. Don't overthink it. I started to do that right away. And I just said, well, slow down a minute. It doesn't have to be something really elaborate. It just kept it simple. I tried not to have a lot of clutter, but I also wanted it to be, put them off a little bit so that it wasn't too easy. I developed a case study. So I did look at some real patient cases that were septic here, and I developed the sepsis escape room around that. Location, I would have liked to have a bigger room. We had a patient room that I set up the escape room in there, and it got really warm quickly when there were closed doors, even with 4 or 5 people. Equipment, again, I kept it to a minimum. I did add a few extra items to distract the players. Clues, it helped if the staff had previous escape room experience. If the people didn't have experience in escape rooms. They kind of weren't getting the concept. So it took them a little bit longer if they hadn't been in an escape room. Ambiance. So I did play the Mission Impossible theme song on repeat through a portable speaker just to kind of create a little bit more mystery and stress around it all. Pilot testing. I did have a group of clinical students trial the room, and then I made adjustments based on their feedback. Again, that incentive was a good way to go. It created that competition. And then debriefing. We debriefed with every group that went through there just so that we could point out, you know, this is what you did well, this is might be what we missed. So it was a lot of fun doing the sepsis escape room. Next, I'll talk about why we decided to use the QIN device and some background on that. So blood culture contamination is associated with increased antimicrobial use, length of stay, and hospital cost. To address this problem, blood culture diversion has been developed as an additional measure to reduce contamination to targeted goals. The estimated hospital cost for each false positive blood culture is $3,073 to $4,818, with an extended length of stay of 1 to 8.4 days, leading to greater than $1 billion in excess spending yearly. The Clinical Laboratory Standards Institute blood culture contamination goal for the US is less than 1%. And then ED blood culture contamination rates exceed inpatient rates due to high staff turnover, patient acuity, limited time, and insufficient training. I will say, though, that our emergency department had a lower staff turnover, but we did have a problem with higher blood contamination rates. So that led to blood cultures being drawn by lab personnel only. So that led to a little bit of a delay in getting the cultures drawn, especially at night if there was limited staffing. So that was one of the reasons we decided to go with a QIN device. So how do you minimize contamination rates with blood cultures? Education, skin disinfection, avoid using catheters to draw blood, using aseptic technique, prepackaged blood culture kits, and monitor contamination rates and report surveillance data to phlebotomists and nurses. So specimen diversion systems, again, I just want to reiterate that it was more about the timeliness of our blood culture collections than anything. That was the reason why we decided to go with the QIN device. But the QIN device or specimen diversion systems eliminate the first 0.15 to 1 milliliter of blood containing the non-sterile skin fragments. It improves clinical value of blood cultures or reduces false positives. It provides safer, more effective, and lower cost treatment, and also leads to appropriate antibiotic therapy, decreased lengths of stay, and combats the multi-drug resistant organisms. Systematic literature review found diversion devices are capable of reducing blood culture contamination and identifying a true infection. So using the diversion system also leads to better stewardship. So your more responsible use of your diagnostic tests to improve patient outcomes while minimizing potential harms and reducing cost. One advantage of the QIN device over some of the other devices like Steripath is that QIN device uses only 0.15 mils of blood compared to 1.5 to 2 mils with some of those other devices. I will say we did have our QIN reps come on site and gave education to all of our emergency department staff, and they've followed up with us numerous times to make sure that things are going well. So this next graph here just kind of shows where our blood contamination rates were. So they were pretty high up here for a little while back in 2022. So the QIN device was actually implemented in our lab, looks like September of 2022. So that helped decrease any contamination rates there. So you can see once it was implemented, our rates were greatly improved again. And then we kind of did have another little spike there. I'm not sure what happened, but again, QIN device implemented in the ER. That was just this past December. And again, our rates greatly declined as far as contamination goes. So since implementing that QIN device and the ED, there was a total of 44 blood cultures collected in March, and 17 were documented as having used the QIN device, and 0 of those were contaminated. There were 3 contaminated cultures for a percentage rate of 6.8%. And then during that time in March, the lab collected 213 blood cultures and only 1 contaminated culture. Overall, our percentage rate was 1.6. So then the last implemented change I'll talk about is our sepsis quality indicator tool. So that was one thing that members of our nurse practice council said was kind of a barrier, is really kind of having a busier quality indicator tool, not being able to really follow it and know what to do next. So this first part here was our front page, and on the back page, it had recommendations for your fluid administration. So we kind of, I would say, use the Plan, Do, Study, Act to improve the process with our quality indicator tool, because this was an updated version from our previous. So we've had a number of quality indicator tools, but like the previous speaker said, there are a huge array of tools out there. Again, what's best for one facility might not work for another. But like this was one that we kind of looked at when we were planning our new one. There's a lot of nice tools on that Sepsis Alliance website if you're looking to develop something new. So this is our initial edited tool. We got rid of that crystalloid fluid recommendation on the back, and then we went through and put down like what each person is responsible for. So like what's the primary nurse responsible for? What's the provider responsible for? What's pharmacy responsible for? So kind of like everybody knew their role. So we did implement that for a short while, and then we at the same time we implemented our sepsis alert. This is our current sepsis quality indicator tool now. It's a little not as busy, a little color coded there, a little easier to follow. One of our ICU supervisors developed that. So we put that into use in March of 2024. Our compliance was at 66% then. Once we put this new tool out, we got that new abstractor, and it was right around the time of the skills fair, our compliance increased again up to 89% with our sepsis bundle. So some challenges that we identified with the implemented changes that we made were with the sepsis alert, it was being utilized, you know, fairly often when we first launched it, but staff have kind of fallen off on using it. The sepsis alert was nice because it just alerted everybody, it's from pharmacy to the lab to the physician to the nurse, you know, that this patient's septic and we need to, you know, be cognizant of time and make sure that all the interventions are met for that patient. With the escape room, again, some barriers there were the staff who were new to escape rooms. They just really weren't sure what to do. Having to have the rules with the escape room to follow the order and combination locks, because some people just wanted to kind of win and get out of there with the best time. But I'm like, you got to win by treating your patient appropriately and making sure they're going to survive sepsis. And for me as an educator, it was kind of like, how am I going to top that going forward with education? So that's been a little bit of a challenge for me now. Handoff communication, it seems to continue to be a challenge. We just need to continue to make sepsis a normal part of our handoff report. Order sets, our quality specialist, Suzanne, has really started to highlight the positive when it's noted that the physician is using the order sets instead of always focusing on the negative. So we're just really reinforcing those positive behaviors. And then it's just difficult to give real-time feedback, and that's really what staff want. It's just difficult to give real-time feedback when, you know, it takes a while to extract the data and find those fallouts. So I'll talk a little bit about critical access hospitals. So they're designated by 25 or fewer acute care inpatient beds. They're located more than 35 miles from another hospital. Annual average length of stay is 96 hours or less for acute care patients, and they need to provide 24/7 emergency care services. As of April 2024, there were 1,368 critical access hospitals throughout the US. Critical access hospitals are still able to care for critically ill through technology and collaboration with tertiary centers. Nurses at critical access hospitals really need to be generalists and care for all patient populations. So some rural health challenges are poverty, lower education level, unemployment, lack of health insurance, transportation, poor health and chronic illness, psychological distress, a lack of providers, so often using physicians' assistants or nurse practitioners, a lack of resources like equipment, education, staffing, antimicrobial stewardship programs. Um, lactate testing could be a barrier because of the cost and required equipment. And then also central venous pressure monitoring may not be available. So those patients that are refractory to that fluid bolus challenge would require that CVP monitoring and vasopressors. And then lack of exposure to high acuity patients in some of those rural health settings. So opportunities for rural health when it comes to sepsis is to make sure that you have some sort of sepsis screening in place and develop a sepsis quality indicator tool. Also, it's been found that reporting quality measures decreases mortality and increases guideline compliance. And then ongoing education for nursing staff and physicians. Engage in knowledge sharing. So knowledge sharing, like we're doing here, or sorry, I just heard something overhead. Or networking like what I did through the Sadaho organization. Infection control protocols should be in place, utilizing telemedicine whenever possible, and then communication when transferring patients to other facilities. That's one thing I think that we definitely still struggle with, of not getting all that critical information when it comes to fluids administered and things like that. Thank you for your time. And if there's any questions later on, I'll still be on to answer.
Thank you so much, Melissa. That was an excellent presentation. I love the escape room and just all the information that you were able to provide for us today. So we just have another slide here that Stephanie will talk about, and then we'll open it up for Q&A, and please start putting anything in chat, and we'll love for you to come off mute to ask questions.
All right. So as Melissa had mentioned, the Sepsis Alliance is out there. They have several different tools and resources that can be utilized. And sepsis is known as, our September is known as Sepsis Awareness Month. So we want to make sure that you are out there. We're promoting sepsis. We need to get our communities involved. They have the Faces of Sepsis. They have a toolkit that you can utilize. And then also the Sepsis Alliance Resource Hub. And like I said, we want to spread that Sepsis Awareness Month is across social media by sharing posts throughout the month. You can tag at Sepsis Alliance or use the hashtags Sepsis Awareness Month and SAM 2024.
Stephanie, can I interject really quick?
Yes.
Okay, so I'm Carrie McDermott. I'm a communications director with Great Plains QIN. We love to highlight work that's being done in our communities and organizations, and even at your personal family level. So if you have a story related to sepsis in your community or in your hospital or nursing home, we would love to highlight that throughout September. It's one of the joys of my job is kind of showcasing the good work that's happening in the Dakotas. So just like Melissa just shared with Avera, you don't have to come and give a presentation, but we could have a 5-minute conversation and we could highlight some of your good work in the hope of spreading best practices and things of that nature. So I'll put my email address in there, and feel free to reach out to me if you have. Oh, Kelsey just put a link there. You could start there by just submitting that prompt for a success story. Thank you.
All right. Thanks so much, Carrie. We will go ahead and go into the question and answer portion of the call. So if anybody has any questions, you can go ahead and come off mute or type them into chat. Like Melissa said, she is going to be on for any questions that you may have.
We were really intrigued about this escape room. Is there a way we could get a lot more information on how we would go about making it so that it's beneficial and information is being well received instead of, because it's a great idea, but we want to make sure we do it correctly.
Yeah, I can definitely forward all the resources that I was given. I believe I remember asking Michelle Hofer for permission to do that for another hospital that was interested in it. And yeah, and it really helped to have the examples to kind of build mine off of. But again, I would just really recommend don't overthink it. And I was just surprised at how well it went, and really the information I feel like was retained very well just because of the interactive environment. So I can forward that information, and then the host can get it out to you maybe.
That'd be good.
Okay, thank
Yeah.
you.
Yep. So Suzanne,
Do you see the questions in the chat? Or do
Yeah.
you guys want me to relay them?
yep, I was wondering, I know Suzanne's on the call. Suzanne, do you want to speak about the compliance with the order sets?
I can do that. Except I'm echoing.
Suzanne, do you want to try one more time? She's probably really leery of.
Is it better now?
Yes.
Okay. Order set compliance for us for the, nope. Yeah, I'm a little leery about this now.
I know a little bit about, like, I know that Suzanne with Quality meets with our physicians on a regular basis. And so really just individualizing those order sets and tailoring it to the physician's needs, I think has helped a lot. And then also, like Susanna said, she's done that positive reinforcement when she knows that those physicians are using the order sets, just really reinforcing that positive behavior there. But like I said, I think really it was just getting, making it easier for them to use, and kind of tailoring it to each individual physician.
I didn't get a chance when Melissa was presenting at the end just to pipe in. I'm Michelle Hofer. I got married, so my last name's Jury. But if she wants to sure send those out, that's fine. Or
Awesome.
I can be contacted too if anybody has any additional questions.
Thank you.
All right. Are there any additional questions out there that anybody has?
There are some comments in the chat.
Okay.
So someone said we're seeing a significant percentage of our residents come back from the hospital with the diagnosis of sepsis, even when they don't obviously meet the criteria, which our quality coordinator is concerned will start affecting our quality measures. She said, I'm not familiar enough with the quality measures in skilled nursing facilities and upcoming changes that will include sepsis. Can anyone speak to this? And do we know how this could negatively affect skilled nursing facilities? If someone does have a response, maybe if you could follow it up in the chat. And then someone else commented, I'll add on this a bit too for St. Luke's. Our abstractor is giving close to real-time feedback on fallouts, which allows us in turn to have real-time conversation with our providers.
That's awesome, because I know, yeah, that was one of our like barriers with Nurse Practice Council, or what they gave for feedback was, yeah, really getting that real-time feedback was more valuable than at least the nurses that voiced their opinion thought it was more valuable than finding out later on. So I don't know the answer to that question about the skilled nursing facilities, but I did include our nursing home and our sepsis escape room. Like, I had them come and participate as well. That way they, you know, got the education and are able to hopefully realize when the patient's septic as well. So I thought it was important to include them, because a lot of the time they're sending us patients. So.
Mhm.
And in regards to sepsis and skilled nursing facilities, we can definitely find something, some extra information, put it out there on that listserv that will speak to that may help you out as well.
Yeah.
All right. Well, as always, we want to encourage you to stay connected with us by accessing these resources and many others that we have on our website. We have the podcast Q-Tips for your ears. We have that community coalition listserv. And then also you can connect with any of the QI advisors on our webpage as well. As we close out the question session, a reminder that attendees will receive a certificate of participation for submission to applicable accrediting licensed bodies for CE credit. This certificate will be sent via email. Great Plains Quality Innovation Network is an approved provider for continuing education within the North Dakota Board of Examiners for Nursing Home Administrators and the South Dakota Board of Nursing Facility Administrators. We ask that you please complete the evaluation form. The link is going to be in chat, and we will also email that out to registrants following today's session. So please complete that and help us plan and coordinate for any future events. Just want to thank you again for joining us, and enjoy the rest of your day.
Thank you.
Bye-bye.
Thanks, everyone.